Okay, what I'd like to do is we're going to go ahead and review some things before we get into this final part of E&M coding. I also have another assignment. It's going to be 2 assignments this week instead of 1. Um, it's just I forgot my CPT book and my ICD-9 book, so I can't really create the answer key yet. So I want to take my time with that. So there'll probably be an assignment later in the week, probably Monday or Tuesday. It should only be about 5 questions though, so it won't be too much, but it will be in addition to what's already on Kia. The things that I want to review real quick are, first of all, remember the 3C note. Okay, and the requirements for the 3C note are that a physician only has to list 3 chronic conditions, at least 3, and then give a brief statement from the patient's perspective, which means essentially how is the patient compliant or not compliant in their management of this disease. The caveats are if that you use the 3C note, you do not have to use 4 descriptors. 3C equals 4 or more descriptors. If you use a 3C note, you must use the 97 guidelines. There is I'll just say that that's going to be something you'll need to know for the assignment. The other thing that I wanted to remind you is the review of systems. Remember that if a provider says remainder of ROS is reviewed and negative, they technically get credit for everything. So it becomes this 10 plus review of systems. And then there is one assignment where I noticed on the chart it says past family history reviewed, social history reviewed. For now we're going to count that just because it's going to depend on the policy in the office that you work on whether that's acceptable or not. So for now we're just going to count it for this week, and then we'll go from there. So remember the descriptors. You might have to go back and kind of look through your notes or the watch the videos again, because what we're going to do is we're going to pull all what we've been learning for the last few weeks, and we're going to actually determine what the code is. So in order to do that, we need to know what the HPI is, what level it is. Remember that it can be problem-focused, expanded problem-focused, detailed, or comprehensive. We need to know what the exam is, and remember that with the exam, you need to use the 97 or the 95 guidelines, whichever is most beneficial to the physician. They can be problem-focused, expanded problem-focused, detailed, or comprehensive. For the medical decision-making, it's composed of the diagnosis points, the data, and the risk. Okay. Remember that you can drop one of them, 2 out of 3, so you only need 2 out of 3. Most of the time we do drop data, and then whatever is the lowest, and by lowest I mean lowest in point value, that is the determining factor for the level. What we do then, once we know what all the levels are, is we come over to the right hand side. Now, before I go there, this left hand side for all evaluation and management codes does not change with the exception of preventative visits. Preventative visits are driven by age. So all you need to know is the age of the patient, whether they're a new patient or an established patient, and that gives you the code regardless of the documentation that's presented. For every other one, you're going to evaluate the documentation in precisely the same way. The only thing that changes is over on the left side as to what levels create which code. If you look in your CPT book under these codes, and by these codes I'm looking at the established codes right here, and you see 212, 213, 214, they will say that requires 2 out of the 3 elements: a problem-focused HPI, problem-focused exam, and straightforward medical decision-making, for the 212 as an example. There's also a phrase in there, and I don't remember if it's in this year's edition or not, about meeting or exceeding, which means that if you have a problem-focused HPI an expanded problem-focused exam, and a straightforward medical decision-making, the lowest guy wins. So if you drop medical decision-making, problem-focused is lower than expanded problem-focused, so it drives the code to a 212. If you drop the exam, then the HPI and the medical decision-making are both the same, so it's a 212. If you drop the HPI, the exam is an expanded problem-focused, but the medical decision-making is straightforward, which is lower than expanded problem-focused, and is now a 212. And that holds true for all of these codes. Okay. Now, I've mentioned a couple times dropping. Notice that up here where it says established, I have this 2/3, which means that I get to drop one just like I dropped in medical decision making. Alright, so I'm going to go through my example and show you how to get the code, and then we'll go into the new patient. Okay, for my example here, just real quick briefly to review, this was a detailed history, a detailed exam, and I believe low complexity. Okay, so I have a detailed history, a detailed exam, and low complexity. Now, if you're working in a physician's office and you're trying to get the best code possible within the limits of what the documentation provides, and you can drop one of the codes, typically you're going to drop the lowest. So in this case, we're dropping medical decision making, which leaves us a detailed HPI and a detailed exam, and now we have a 99214. So if I drop medical decision making, it doesn't matter which one of these two are the same, and I just come across and I get a 214. Okay? And that is how you determine what the level of service is for a particular code on an E&M chart for an office visit. Now, for new patients, the process is exactly the same. We evaluate the documentation, and then we copy over what we found. The difference is that you'll notice things have kind of shifted. First of all, a 201 is possible, where a 211 is not possible. This is for a nurse visit only. And notice that things have shifted to where the straightforward covers the 201 and the 202. That the low complexity now is at a 203, just like the low complexity was a 213, but now I need a detailed exam and a detailed HPI in order to get that 203. So it's different criteria, and this is taken right out of the CPT book. So I'm going to take the same example, and you'll see how the code kind of shifts a little bit. So I've got a detailed HPI, a detailed exam, and low complexity. And notice how before it was kind of a line with a sharp uptick going to the low complexity, and now it's a straight line. So that's what I wanted to show you is that the pattern is different. Okay. And then that's how we get a 203. The difference between the consult codes here, consult codes may not be around for much longer. Medicare stopped covering them last year. Regents actually stopped covering them in October of 2010, and the general trend is that for the most part, whatever Medicare does, within time, insurance companies, the other insurance companies will follow. Now, we need to know what kind of an important thing here is: how do we define a new patient? Okay. The best way to understand what a new patient is to understand what an established patient is. An established patient is, see if I can just type it right here, is a patient who, with the same group, in the same specialty, in the last 36 months or 3 years, has had a visit. So at the office that I'm at, if I come in there and I've been to that clinic before, in that network, it's a family practice, same clinic, and I've been there within the last 36 months, I'm an established patient. Now, if I haven't been there in 38 months, I'm a new patient, even though I've been to the clinic before. Now, in the building that we're at, as part of our network, we have a neurology group. They're downstairs. So let's take a different scenario. Let's say that I've been going to that neurology group for the last 4 years consistently, twice a year. And I decide that I want a family practice physician who's a little bit closer so I can consolidate my visits. When I show up to the clinic that I work at, I am a new patient. Because even though it's the same network, and even though I've had visits within the last 36 months, it's now a different specialty. I've moved from neurology to family practice. And so I am considered a new patient. Okay? Now let's say that there's another family practice clinic that's the same network, and it is just down the road. And my provider has left, and I decide that I want a new provider at this clinic. So I'm moving from Clinic B to Clinic A. Both of them are family practice. Both of them are part of the same group. And I go in every year for my annual visit. Okay, because it is the same group, same network, because it is the same specialty, and because the last visit was within the last 36 months, I'm not considered a new patient even though I've never been to Clinic A before. I'm considered an established patient. Now something that's a couple more examples is that let's say that I go to the ER and then I go follow up to a clinic that I've never been to before. Not even in the network, but it's owned by the same hospital as the ER that I went to. Well, ER physicians are considered a different specialty than family practice, so I would still be a new patient showing up at the door. The one kind of quirky thing about this is that lately there's been a trend for looking at urgent cares. There is no specialty code for urgent care within insurance companies. And so what they have done is they have considered urgent care to be family practice. As an example, Valley Medical Center has 4 urgent cares, I believe. 3 or 4. If I go to the urgent care, and then for the first time I go to one of Valley's clinics, family practice clinics, because urgent care is considered the same specialty as family practice, I am not considered a new patient when I show up at the regular clinic. I'm a new patient when I go to the urgent care clinic, if I've never been there before, or within the last 36 months. But when I go to the family practice clinic for follow-up care, I am considered an established patient. Let me know if that doesn't make sense as quickly as possible, because it's an important differentiation to make. There is a diagram, and I don't have the page number in your CPT books, that shows a flowchart of how to decide whether they're an established patient or a new patient. That may be helpful to some. If not, we need to get that squared away just to make sure that everybody understands how to determine between a new patient and an established patient. Okay, I'm going to go over a couple things that are important professionally but are not covered in the assignment, but you will need to know them. Alright. The first is time coding. Physicians, once they learn time coding, they are apt to use it more often than they need. Time coding is a way of documenting a specific phrase so that the level of the code is determined by time, not by the documentation requirements. So for example, let's say, probably the easiest way is just to make this up here. Let's say that as part of this note, I see something like this: more than 50% of the 35 minutes spent with the patient was spent in counseling to prognosis and treatment options. Okay? If you see a phrase like this, and there is one in the assignment, it does not make a difference in the code, then basically all of the documentation evaluation goes away, and we do not use it. The trick to this, and this is what most physicians do not know, is that there are only 7 specific criteria that you can use this with. I've listed 2 here. Prognosis is one. Discussion of treatment options is another. Lab results or imaging results, any sort of diagnostic studies or tests, can be considered a valid scenario in which to time code. Talking about the importance of compliance with the chosen management options. Talking about patient and family education. Those are 5. There's 2 more that pop up every now and then. They're listed in your book. If you look in the Evaluation and Management Guidelines, there's a section on what constitutes counseling. Now, in documentation, there are 3 things that have to be present. The first one is this more than 50%. They need to specify that. If they just said that they spent 35 minutes with the patient counseling them, it does not count as time coding. The second thing is that we need to know how many minutes were spent with the patient. And then the final one is the nature of the counseling. So we need to know what was being counseled. These 3 elements must be present in order to activate time coding. Once it is determined that this note can be time coded, you do not need to evaluate the HPI, you do not need to evaluate the exam, and you do not need to evaluate any part of the documentation. Just this part, that these 3 elements are there. Now, how do you determine the code? If you look at the office visits in particular, for established and new patients, there is a little phrase in the description or in the notes of the code that say something to the effect, typically physicians spend X minutes with a patient for this level. Whatever that X minute is, that is how you determine what the time code is. So for example, I have 35 minutes here. I know that the time coding for 99214 is 25 minutes, and for 215 is 40 minutes. Well, I haven't gotten to the 40-minute level, so I can't charge a 215. So this note would be considered a 214. Okay? So that's time coding. Time coding will come up. It's established for situations where it's kind of these odd kind of visits where there's really no diagnostic effort being put forth. The second thing I want to talk about, and we haven't spent enough time on it, is modifiers. Now, I noticed in last quarter's assignment that modifiers are being put on diagnosis codes, and for the most part I ignored those. But I want to tell you right now, modifiers do not belong on diagnosis codes. they only belong on CPT codes. The two most popular ones that are used are the 25 modifier and the 59 modifier. The 25 modifier is for saying that this E&M service was done and is significantly separate from the other items that are on this claim. A 59 modifier is the same thing, except it's for procedure codes. Lab and radiology codes never get a 25 or a 59. So we don't have to worry about it for there. But let's take this as an example. We're having 99214. Patient also came in for their annual exam, so that's a 99395. Which I think is for a 40-year-old. And on top of that, we also froze a wart, which I think that's the right code. I'm kind of flying off the cuff here. So I have 3 codes. Oh, and let's throw in a urinalysis too. Okay, so I have 4 codes. Now, first of all, like I said, labs and radiology never get a 25 or a 59 modifier, ever. Okay. Secondly, the way that we work this is that all of the remaining codes, so these 3 codes, only one cannot have a modifier on it. Alright, so it's pretty much arbitrary which one you pick. Usually you want to pick the one with the highest RVU value, which we haven't gotten into RVUs, but basically the highest reimbursement amount. So for now I'm going to say that it's this this preventative visit, this 99395, which means that these other 2 need to have modifiers on them, 25 or a 59. It's real easy which one is which. 25 goes with an E&M, 59 goes with a procedure. So all I do is put a 25 and a 59. And now this claim can go out the door. If I don't put those on there, those 2 procedures will be denied. And what they will do is out of those 3, they will pick the one that is reimbursed the least. They'll reimburse you for that one, and then they will deny the other 2 as non-reimbursable because they are part of, the other code. So this is a way of saying, no, this is different. This is a different service. Don't deny me. And then, this will get paid the way that you would expect it to. Okay, so for the assignment, what you're going to end up doing is you're going to be picking the level of the HPI, picking the level of the exam, picking the level of the medical decision making, and then you're going to tell me what the established patient code is, and then we're going to pretend that these are new patients, and that we are going to say that what's the new patient code. Now, this might sound a little weird, so I'm going to try to make it as clear as possible. I don't really want to spend a whole lot of time evaluating documentation. More than what's necessary. So for the new patient codes, all I want to do is take the levels that you've determined for the HPI exam and medical decision making and just put them in that new patient grid and find out what the new patient code would be. The reason I say that is because with medical decision making, if you say, okay, this is a new patient, now it's a new problem, which could change your medical decision making, and I don't want to worry about that. So I just want you guys to have practice in determining what a new patient code is. Okay? I want to check my notes and see if there's anything else that I want to talk about. The assignment that I'm going to be creating probably Monday or Tuesday, and there will be a video to go along with it. Actually, I have time now. I'll go ahead and do it because this is actually a good chart to do that with, is charge capture. You'll notice that the bulk of this note is all about the office visit. And that's why we're spending so much time with the office visit, is because there is a lot that goes into it. Professionally, you're going to need to know this. For the CPC exam, they will give you elements of it, and then they will tell you others. So they may give you a brief HPI where you have to determine what the level of the HPI is, but then they'll tell you that the exam is detailed and the medical decision making is of moderate complexity. So they kind of shortcut that, but this is an important skill to know. It's one that most coders do not have coming out of school. So master this and you will be that much further ahead. There are elements in here, though, that are important to note. And generally they're in the assessment and plan, sometimes in the exam. You'll notice here this diagnostic testing results. Okay? These are all labs that have been ordered. If they say we gave shots or whatever, those also can be coded. Now, there's a little trick which is kind of nice with this particular EMR, and that is that anything that's ordered, which generally means chargeable, is under these orders. So what I'm going to do is with the charts that are out there for this week, I am going to go through and code everything that's on them. And then you will go through and code everything that's on the charts. I don't think it will take long because, like I said, most of the work is going to be in determining what the office visit is. The rest of it is going to be looking up, okay, where's the basic metabolic panel, which will just be a simple lookup in the CPT book. This will be something that will be important for you to do as a coder, so we're going to get practice on it this week as well as determining what the E&M level is. Alright, that's it for now. I will try to have the extended assignment out Monday or Tuesday, but we'll also extend the deadline until people are finished. Oh, also one other point. I did grab the conference room for February 8th and 23rd. I'll put it in the calendar. And then also in March, the 2nd and 3rd week. The final is on the 4th week, so I don't think it would really be helpful to meet after the final is done. So we're going to meet the week before so we can have kind of a review. You guys can ask any questions that you want, and we'll just kind of keep the general forum open and get you guys ready to take the exam.